Well, Jerry, it's just 1 minute before we've got all the board members online. I think we'll go ahead and get started with the preliminary, if you're ready.
Yes, Mr. Chairman, we're ready to start.
Okay, thank you. We welcome everyone to this meeting this morning. We'll go ahead and call it to order. We have members of the public in the meeting with us. We appreciate your attendance. We also have officials from our area hospitals, and of course, always appreciate the information that you can provide for us, and we will get to later in our agenda. Also in attendance, we have Director Rakow, James Corbett, as well as other staff from Eastern Idaho Public Health. We are meeting utilizing Zoom conferencing this morning, along with those who are logging in. We have a room set up at the Eastern Idaho Public Health building where members of the public can come and attend on the location. We have a full board with us this morning, so I'll go ahead and call the roll call for the board. Please introduce yourself as well, and that'll help us ensure that we've got a connection with you. Jefferson County. Commissioner Young, we've got you muted.
Yeah, Commissioner Shane Young present.
Thank you. Madison County.
Commissioner Mendenhall.
Fremont County.
Commissioner Miller present.
Clark County.
Commissioner Shenton present.
Lemhi County.
Commissioner Minor present.
Custer County.
Commissioner Butts present.
Teton County.
Bill Lake, the appointed representative from Teton County, present.
Our physician representative.
Dr. Barbara Nelson, present.
Thank you, Dr. Nelson. And of course, I'm Brian Reed from Bonneville County. First item on the agenda is approval of our August 13th Board of Health minutes. I reviewed those and did not see anything out of order, but do any of the other board members see any changes that need made?
I move we approve the minutes from the August 13th meeting.
Thank you.
I'll second.
Okay, I heard a second from Commissioner Miller. All those in favor say aye.
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 Anyone opposed? Okay, thank you. We will move on to a report from the Idaho Associations of District Boards of Health Executive Council meeting. Mr. Lake, I know you were at that. I did watch the meeting yesterday, the recorded version of it. Was not able to attend on the day of, but would you help bring us up to speed on that?
Yeah, thank you, Chairman Reed. I'll just go over a little write-up I did after the meeting to get my notes in order. The purpose of the call was to have discussion and recommendations for the upcoming legislative session. Since at that time we weren't aware of any specifics for the special session, most of the discussion just centered around what each of the districts were doing to prevent and slow the spread of the COVID virus. I was at one point, I guess at a couple of points, some of the board members indicated things that they felt strongly about, that maybe some districts or people are overreacting to this virus, that it's not as dangerous, as bad as it's being portrayed. And things like that, which disturbed me considerably, I have to tell you. One statement was made that, you know, the kids can handle this thing. There's no studies out there that show that this is being detrimental to the kids, things like that. And again, I don't know where everybody's getting all their information, but I basically told everybody on the other boards that we're taking it seriously here in Eastern Idaho, and that we're taking aggressive measures because we know and we understand that if we want to keep our kids in school, our businesses open, and our healthcare system from not being overwhelmed, that we need to keep the spread of the virus under control. I made that point very clear to them, and that's why we were taking the actions that we were taking here to do that. I also noted on that call that there was a chat session going on that a couple of folks from the public had indicated that, again, that they were opposed to us unelected officials mandating face coverings, and that we should let businesses decide who should wear masks or whether they should require masks being worn in their businesses. After seeing those, I reiterated that masks are there to protect our fellow human beings, not just ourselves. That seems to be a concept that some people just can't seem to get their arms around. So let me see here. At that point, we did have some good discussions. I will say that for the most part, most of the board members across the state certainly understand the significance of this. And I think after our discussion that everybody left that meeting thinking about where they might want to go with this. So all in all, I think the meeting was worthwhile because we do need to continue to have these discussions with people and educate the public about the importance of this. And as far as getting the kids back in school, I know most of the districts around our area are getting ready to open up. And I'm just hoping that we don't see any big outbreaks that would cause anybody, the school district boards, to have to go in and shut them down. So with that, is there any questions from anybody?
Any questions from any board members?
Was there any discussion about the legislature potentially stripping the boards of health of power?
Yes, there was, because that came up, but since we hadn't seen what was actually going to be going on, there was some discussion about it, but we didn't have any conclusions or any strong feelings one way or the other. It was like, well, until we know what the legislatures want to do, there wasn't any point in really discussing it.
Thank you.
Well, thank you, Bill. We appreciate you representing us on that board. I have to say that I was disappointed with some of the comments during that meeting and with some of the dialogue. I felt like the meeting was poorly run, to be frank. I felt like they got off topic a lot, and that they didn't take some of the items seriously enough. And I was disappointed. I did appreciate the comments that you made, and I appreciated you representing us. I just came away feeling that it confirms what I've said in the past, that this health district, Eastern Idaho Public Health, under the direction of Director Rakow and our epidemiologist, James Corbett, along with all of her other supporting staff that have worked so hard, are far ahead of all the other health districts. I've seen that from the beginning. We have a plan that was put together here in our district that responsibly responds to the situation locally. And, that plan was based on science. It was based on medicine. We have a board that is fully educated on the virus. We have a a board member who's a physician that we rely on and that provides us information medically that we need to know. I just have full confidence in our board, and I know that all the board members are trying to do the very best that each one of you can, that we all can. There's absolutely no political agenda. There's no motivation for power in any way. We're simply trying to perform the responsibility that we were called on to do. And so, again, I appreciate all those at Eastern Iowa Public Health who have worked so hard. And unfortunately, we are in a district that's had some high incidence of infection of the disease here. And for across the state. Some areas, may not see that because of their lower populations. We're seeing it, but it appears that because of our response plan, because of the measures we've taken, it's coming down. The last 3 weeks, it's been trending down, which would be very typical of what we would expect from our actions. And so, again, appreciate your representation, Bill, and on a difficult situation. And I'm glad for our health district. Any other discussion from the board, or Bill, would you like to close with anything else?
I would say that I got the impression that some of the other boards or several of the other boards may not have been getting the education that we've been going through by having the medical professionals come and talk to us from across the state. So I don't know for sure, but I suspect that maybe some of those boards haven't had that opportunity to hear from some of these folks.
That's true. That's most likely true. And so appreciate Jerry for all the work she's done to help keep us informed. And for, again, our physician representative, Dr. Nelson. Some boards don't have that. And so we are fortunate. Let's move on to item 4 on our agenda, which is review of public comment. We again received several emails of comment this week and appreciate each one of them. I have to say that they were very well informed, very well written, and gave us some great information. And so we appreciate each one of them. Just in summary again, and then I believe most of them will be discussed during our meeting today and questions answered. But we did receive several emails from Lemhi County residents that were concerned because of the increase in case numbers in that county and the changes that we made in our high risk category. They were concerned with how that would affect them up there. And we will be talking about that later in the meeting. There were also letters concerned about school districts, which is understandable with the beginning of school getting very close. They mostly wanted to ensure that masks were face coverings were being used in these school districts because they wanted to ensure that it was done as safely as possible. They mentioned in particular Madison School District, Jefferson schools, and District 91 was mentioned specifically to make sure that, again, that it's all being done safely. I have to say that I believe that we do have a great partnership with all the school districts. I know that Jerry and James works very closely with them and to keep them informed. They, or the majority that I'm aware of, reach out to us for information. And that's the way I think that partnership should work. And we, at least I believe that our goals are really in line, that we want the very best for the children, for all the students. We want schools to be safe and for the teachers and the community and the students. And I know the school districts want that very thing. And so again, we will continue to have that working relationship together and to make sure that that's all done as safely as possible. But we appreciate the schools reaching out to us and working with us. We had a letter come in last night that had questions about case counts, about when releases are done, how that relates to testing, and some good questions that will be answered during our discussion a little bit later in the agenda. Are there any other items of public comment that board members want to highlight before we move on? Like I say, most of this will be discussed during the meeting.
This is Bill Lake. I got a couple of calls yesterday about the change to the plan. And I guess later on, we talk about when we make changes to our plan, do we do press releases so the word gets out? And also, I did notice that on the website that those changes we approved a week ago didn't reflect what was on the website, if I was looking at it correctly. So we might want to talk about getting that updated sooner.
Jerry, do you want to address that before we move on?
And yes, Mr. Chairman, and Bill, thank you for that. And yes, we recognize that. Part of the challenge that we have with that particular document is it's not an in-house document. And so we have to work with our outside designer that has developed that for us. And it's taken a little bit of time this time. In addition, with other proposals that are being considered today, we are prepared to have that updated very quickly today if in fact those changes are made. We have not in the past done a press release. I know it has been communicated on our Facebook page, but if that is something the board would like, we can certainly do a press release for any future changes.
Okay, thank you. Any other comments from board members about the public comment? All right, thank you. We will go ahead and move on then to item 5 on our agenda, which is a report from our hospitals. Again, we appreciate each one of them. They are really the driver that helps us understand what we need to do because that's where our focus is to make sure that we are helping them in their needs. Jerry, again, I will ask you to go ahead and introduce them.
All right, thank you, Mr. Chairman. I would also, before I do that, just like to acknowledge that Dr. Martha Buitrago is listening this morning with us. You all know that she's an infectious disease specialist, and for Eastern Iowa Public Health, she is our consultant for infectious diseases, not just COVID, but all infectious diseases that we deal with through public health. So I want to recognize her. She is available if anyone has any questions and is always willing to help educate the board.
Okay, thank you.
Going on to the hospitals, we'll start with Idaho Falls Community Hospital. We have Casey Jackman, the Chief Operating Officer, on the line with us this morning.
Good morning. Thank you for having me. As a comparative report, I thought I would compare against where we were last week. I've mentioned before we have an algorithm where we track the usage of our resources. We are currently 27% below where we were a week ago today. That is related to inpatient admissions, ICU admissions, and ventilator usage. We do currently have, we do currently have 7 COVID patients on the floor, but none in the ICU. In the past, we have had COVID positive patients transferred to us from other communities, other counties, but currently all of those are from our own county.
Mr. Chair, may I ask a question?
Yes, go ahead.
Casey, are you able to share from which counties the patients are currently from?
All of the patients, well, I will have to double check that and verify it with you later, Jerry, but I believe all of the patients that we currently have are from Bonneville County.
Thank you.
Thank you, Mr. Jackman. Are there any questions from board members? Well, that was a good news on your report. We're glad to see that that has come down a little bit this past week, and thank you again. Jerry, who would you like next?
Yes, we have David Hoffenberg, Chief Operating Officer, I believe, from Eastern Iowa Regional Medical Center. I don't know if I got your title right, David. I apologize.
See, Mr. Hoffenberg, looks like you're muted. We're not hearing you.
How about now?
That's perfect. Thank you.
Great. Sorry about that. Nope, you got the title right, Jerry. And I also have Dr. Ballard, our Chief Medical Officer, that that can help fill in. But we currently have 20 patients, so we're staying, steady in terms of our overall volumes. We are still seeing a few patients that are coming in for the emergency department, but are not requiring admission. And in terms of the county origin, we have actually gotten some from outside the district, from the Minidoka area, and the Teton Valley, the Jackson area. But I don't have the exact numbers on me. I will send you an update later, but I do know we have some from outside the district. And then in terms of our staffing and supplies, we're essentially, same as where we were last week. We've had just between 18 to 22 patients at any given time. We, discharged a few yesterday and then have admitted some more. So we're staying right around that 20 mark, and staffing and supplies stay consistent for us.
Okay, thank you. Questions? I guess one that comes to my mind, Mr. Hoffenberg, is we probably expect to start to see a decrease in non-COVID emergencies or patients. Would that be fair to expect at this point of the summer?
Yeah, that is true. We are still seeing a large amount of traumas coming in, particularly from the Magic Valley. We just received 2 yesterday, so we're seeing a bit of some subsiding of our volumes for non-COVID related injuries. So we weren't as busy as we were a few weeks ago, in kind of the midst of July, where we were kind of at our peak. So as school gets back, we tend to see those numbers dip back down. But we are still seeing a large amount of burns in from northern Wyoming and Montana that we just got over the last week. So we're still seeing some, but it's not as busy as it was the last month or so.
Okay, thank you. Are there other questions from board members? All right, thanks again for being with us. Jerry, do we have someone here from Madison?
Yes, we do. We have Dr. Rachel Gonzalez, the CEO for Madison Memorial.
Good morning, everyone. Can you hear me okay?
Good morning, Dr. Gonzalez. Thank you for being here.
So from a Madison standpoint, and Jerry, I'll answer your question first. We've got 2 COVID inpatients, and I'm sorry, I don't know what counties they're from, but I can find out. I'll let you know this afternoon or this morning when I can take a look. So as far as resources at Madison, we're about the same as well. There hasn't been any significant changes. The only change that we've seen in the last week is in testing. Actually, it's the last 2 weeks. And our testing, our numbers, our total testing that we're seeing from the different clinics, we hit, today's what, the 19th, right? We hit the number of tests that we've processed or sent out, collected from other clinics or helped send on as a reference lab. This month, we hit as many as we had done from March through the end of July. And so we just hit that total number very quickly in August. And I think a lot of that just has to do with the change in population, what we're seeing going on in Madison County. Our percent of positives, again, a lot of these are multiple counties, the northern counties that we're seeing, not just Madison County, has been running pretty high, around 15%, Jerry, and I think we were at 18% last time I reported that. But again, you know, we don't have a ton of impacts other than in the lab, where actually we're looking at some travelers to come and help from the lab just because we're so busy. And the ER, like is reported from the other hospitals, is still staying pretty busy. I think that'll start to change with school and stuff as well, seeing the region, but it's been pretty busy still. And I'm kind of reporting on just some other things for you guys to get a feel for it. There are people who are a little frustrated about, and I think this is just Madison County, on our turnaround times. We're back up to some of them taking 2 days, and we were a lot quicker on our turnaround time for results. And so, Jerry, I'm just kind of bringing this up with everybody on the call. I anticipate, at least for Madison and Teton Valley, probably not for Idaho Falls Community Hospital and ERMAC, but they can speak for themselves. I anticipate going into fall, when we get into our respiratory seasons, not necessarily that we'll have a ton of sick people, but I think we're definitely going to have more testing demand. And so however we set that expectations for the hospitals, that might wax and wane as far as our response time. You guys just might hear some of that frustration. Hopefully it was just an isolated incident over this week for Madison, just kind of a quick thing with the kids and everything. But and then the last thing really quick is I was talking with the CEO last night, and I just wanted to report that, you know, in our hospital, we have a parapertussis or whooping cough patient that we've had pretty sick. A lot of resources go into some of those other respiratory diseases where they can get pretty sick. One of the other hospitals has a TB patient that's inpatient, and again, we appreciate that you consider the burns and these TB and the parapertussis and all these other things that continue to go on that require a lot of our staff and our resources, because unfortunately it is not just COVID, or I guess fortunately it's not just COVID right now. But we appreciate you guys help us protect those resources for those other patients. End of report. Thank you.
Thank you, Dr. Gonzalez. We appreciate you being here. Are there questions from board members? Or Jerry, do you have any?
Yes, Mr. Chair, I would just ask any of the hospitals to chime in here. I know in talking with them that they have all over the last month been able to increase their capacity for the rapid testing that is actually available at their hospitals. But from my understanding, it's nowhere near the capacity they would like it to be for those quick turnarounds. I don't know if any of them would like to comment on that. And I would also say that the majority of the tests that are being sent to the National Reference Lab are taking more than 2 days. So a 2-day turnaround time at Madison, we're pretty happy with that, because they have to be sent out of state. So I don't know if the other hospitals want to comment on that. And then I might ask James to give a quick update on Express Lab here in Idaho Falls, that on the work that we're doing in conjunction with them to increase capacity there.
Yeah, this is Casey at Idaho Falls Community Hospital. We don't have unlimited testing capability, unfortunately. We have seen an increase in testing here. The vast majority of outpatient tests we do push to the drive-through testing facility. The testing that we do in-house would be for emergency room patients and potentially exposed staff. The vast majority of the staff that we've had exposed have come through community transmission, not through exposure here at the hospital, actually all of them. But we are experiencing difficulty in getting the testing materials that we need to run the tests. We can turn the tests around quickly, but we do keep a very close eye on the inventory of testing materials we have, just for that reason.
Okay, any other comments on that? Okay, thank you.
Mr. Chair.
Yes, go ahead.
For Dr. Gonzalez on the Madison situation, can she tell me that is BYU Idaho requiring testing prior to kids going back into school?
No, they're not, but they have a lot of significant measures in place to help protect, masking and all sorts of things, but they are not requiring testing. And we're still doing a significant amount of the tests that we follow the same protocols that Idaho Falls Community Hospital did. We're, anything that we're doing in-house because of limited mediums and supplies and just cost based on what we can run it on is for truly the symptomatic or the really sick. Otherwise it gets sent out. But there is some of those numbers, if this is what you're asking, are people who have thought that they've been exposed and it's required for work, healthcare workers or, frontline workers, or, we're trying not to, we do have some that are requests for travel and things like that, but there is a fair amount that people think that they're exposed, and those are the ones that are frustrated because they want to know because they want to go to work.
Thank you.
Sure.
Any other questions? All right, thank you.
Mr. Chair.
Yeah,
Yes.
If I may answer the question that Jerry posed about, or just the update from Express Labs. Casey Jackman mentioned this, the outpatient drive-through testing. Express Labs is the primary driver of that, and does the majority of testing in our community outside of the hospitals. They have been working along with Idaho Bureau of Labs and health districts, Eastern Idaho Public Health and Southeastern Idaho Public Health, to increase their capacity to do local testing capabilities, to increase that throughput that they can achieve, and be a more consistent availability or capacity to do those tests locally here instead of sending those out to those national reference labs. They were able to secure, with the help of Idaho State University, as mentioned, some additional testing platforms. They're in the process of receiving those and setting those up, and training staff to be able to run increased capacity through Express Labs here locally. I don't have the estimated time is probably in the next 2 weeks. Hopefully, if all goes well, but an exact date I don't have.
All right, thank you. I certainly don't understand it all, but I've been surprised that we're still so slow of getting testing ramped up to a way that we can do it more readily and quicker. So I probably don't understand why that is, but I appreciate that. Dr. Ballard, did you have something to add?
Absolutely. Thank you, Mr. Chairman. Here at ERMAC, we do finally have secured enough supplies to ensure that we can do all of our inpatients, if needed, coming through the facility. We've got 3 different resources, one product line from the state and then some from our corporate headquarters. So we are testing most of our inpatients into the facility, all of our behavioral health unit patients, and then we are also saving some for when we have transfers to our nursing facilities into the community. We do not yet have enough supplies to do outpatient testing same day. All of what I was just previously talking about is all same day capacity. So for our outpatients, particularly coming to the ER, we are still sending them to reference labs with anywhere between a 3 and 5 day turnaround for those. I just also wanted to piggyback at what we think is a little bit of a concerning trend. The number, current.
We lost your sound, Dr. Ballard. Mr. Chair, may we give him a second to try to correct whatever the problem is. But I just might mention too, while Teton Valley Health and Still Memorial are not on the line with us. I know that both of those facilities also have very limited rapid testing capability. Again, nowhere near the level that we would like it to be.
Okay, Dr. Ballard, are you back on with us? Looked like he's trying, so go ahead and cut in Dr. Ballard when you do. So that, along with that, I see now that saliva tests are available, right? I mean, we saw that advertised. Are they accurate? Is that an option that is viable?
Yeah, so I'll answer that if I may, Mr. Chair, this James. The saliva tests, if they are approved under the emergency use authorization by FDA, are most likely antigen tests. And we'll talk about this more in detail in a few minutes, but antigen tests can be used as diagnostic tests. So they can say, yes, you have that. However, I will say that they do have they're slightly less sensitive, so they can have a little more false positives and false negatives. As such, if there's still clinical compatible illness or symptoms that are consistent with COVID-19 and the doctor or the provider suspects COVID-19, they do recommend, and the test comes back negative, they do recommend a follow-up PCR or that molecular amplification test that we normally hear about for follow-up or for confirmatory. So we do consider them a case if they do have those antigen tests that are approved by the FDA and symptoms, but we do consider them a probable case. And we'll talk about this more again in detail, but I'll just say we don't treat probable cases and confirmed cases differently in how we do contact tracing or what their next steps are, but we do just want to recognize that they're considered probable cases per definitions established by national organizations such as the CDC and CSTD. So.
Okay, thank you. Dr. Ballard, are you back with us?
Yes, can you hear me?
Yes, we can.
Yeah, so from a testing perspective, I'll just echo what was said before. We have been trying to optimize our utilization of the PCR test, the same-day PCR test. So we have, for the most part, used antigen tests to screen asymptomatics and symptomatics for those that we think are positive and symptomatic and they may have an antigen negative test. We'll follow that up with a PCR for confirmation. So we have ample supplies of the antigen test to be able to do that. And again, for same day capacity, we're looking pretty good. Again, not enough for outpatient testing at this time, but for inpatient, we have an adequate status. Over.
Okay, very good. Thank you.
May I just ask a question? Dr. Ballard had started to say a concerning trend that he was seeing, and I don't know if he wanted to follow up on that comment.
Sure. Thank you, Jerry. I had a call fail on my cell phone, unfortunately. So what I was saying is a concerning trend is that of the 6 patients in our ICU today, 4 of them are between ages 30 and 49. 2 of those are on ventilators. And so we are seeing an alarming trend of a younger population coming through with now more progressively severe symptoms. A few weeks ago, we were seeing this trend of a younger population not quite sick enough to go to the ICU, but oftentimes staying for a few days in our med-surg units. That is now starting to progress to more younger folks requiring mechanical ventilation. So I just wanted to make that known that despite the community's thoughts that younger folks are not as susceptible to this, that is not becoming to be the case here in Bonneville County with the recent cases we've seen.
Okay, well, that is certainly a concern. We appreciate you bringing that to our attention. Other questions? All right, thank you again for all of the hospital representatives, the doctors that are on with us. Dr. Nelson, if you have anything you want to add right now before we move on? Okay, we'll go ahead to move on then in our agenda to item number 6, the 19 update and review. Dr. Nelson, I'm sorry, did you have something?
No, I'm good.
Okay, thank you. So Jerry and James?
So yes, I just wanted to pull up our Tableau site and are you seeing that? Okay. Why can't I get to that? Where's the tabs? Okay, here we go. Maybe refreshing. Thank you. I wanted to just take you to our Tableau site and give a quick overview. We have changed things up a little bit. I will tell you that, again, we're trying to be responsive to the requests of the public as well as the media, quite honestly. And we had changed the way that we were reporting some of our information. And we did get 2 requests just this last week about adding back in probable cases. And so that has been done. On this overview page, we had also had some different information reported, but it's been restructured and we capture the total cases of the current day, again, probable and confirmed. As far as deaths are included as well. We did have a death yesterday in a Fremont County resident, and to date, it was our youngest one yet in his 60s. So that maybe goes along with what Dr. Ballard was saying. We're seeing some more severity in younger ages.
Jerry?
Yes, Dr. Nelson?
Could you please re-explain, especially for the public, how we report probable cases? There's a lot of talk going on in the community that we're reporting close contacts as cases. So could you please redefine that?
Yes, if you'll give me just a moment, we have a list of questions that we wanted to go over, the ones that we get all the time, and that is definitely one of them. So let me just finish reviewing this data, and then we'll jump into those questions. On the response plan, our cases and rates, we changed this as well. It does still have the current active rate for each county here at the top, but then we changed this to show an overlay of the active rate for each individual county on top of the daily cases that were reported. So that is by county, and then by request again, we had removed this, but someone felt it was very beneficial to them, so we added it back on. And this is the chart that you're familiar with of tracking all 8 counties' active rate. So that's back on. Sorry, James was mentioning this last chart here is the district total. Again, with the cases by date and the district's total active rate. If you hover over those, again, it gives you the number as well as the active rate numbers. On the second tab on the healthcare and testing, again, these play into the metrics that we are using in our plan. Icu capacity is the first one, and that is just trending over time, a slight upward trend over time. Just so you know, you can click and highlight on that, and it will give you actually a trend line for more recent, for whatever selection you choose. So the last few weeks, since mid-July, about the last month, a very slight downward trend on ICU beds used. Same thing is for the total inpatient occupancy. And then down at the bottom has the positivity rate for testing. I just wanted to explain that we at Eastern Idaho Public Health do not have the ability to actually capture this information for our region. We do get this information provided to us from the Idaho Department of Health and Welfare. You can see here the last information was from August 8th, and that is a challenge that we have of getting it on a regular and timely basis, and we're in constant communication with the state to be able to get this information. While this shows, as of the 8th, a positivity rate of 18%, it's not the true picture of what we're seeing here in our region. We cannot break it down by county, and this information is only reflective of those laboratories that actually do electronic reporting to the state laboratory. And so many of the rapid tests that are being done are not included in this number. So it is certainly a limitation that we have with this data.
I would just like to add on to clarify if this is the first time someone's seen this, that the hospitalizations and the ICU admissions is for overall ICU admissions and hospitalizations, not just directly related to COVID. As Dr. Gonzalez mentioned earlier, we're concerned about all, the entire capacity of the hospitals to care for all types of patients.
Are there any questions on the dashboard data? And if not, we are happy to jump in and start answering some questions.
Yeah, Mr. Chair, this is Commissioner Young.
Go ahead.
I just wondered on the hospital rates, they spoke about people coming from outside our district. So I'm assuming that those patients are also counted in our hospital rates. For instance, some those that come from Magic Valley are counted in our hospital rates. Is that correct?
Yes, it's the total beds that are occupied in the hospitals, regardless of the residence of the individual.
Okay, thank you.
Mr. Chair, Bill Lake.
Go ahead, Bill.
This is great information, and it's great we're having it here. And Jerry and James has given us a lot of detail about what's behind these graphs. But I'm just wondering, we're getting it ourselves. Is there an explanation for each of these graphs someplace that explain where the data is coming from and what it includes, what it doesn't include, that the general public has access to?
That's a great question, Mr. Chair, if I may. There is not necessarily a tab here that goes over all charts. It's kind of a table of contents, but that's a great idea, and we'll try to put that together. Certainly, we've tried to make them as intuitive as possible, but that's not always the case. On the overview, we do have some definitions for confirmed and probable, and we'll talk about those in just a minute, but we don't have an overall picture of what inpatient use to make sure that they understand what I just described. You're right. So
we can certainly incorporate that.
Thank you, James and Jerry, and certainly it's not a high priority for you, but at some point, if you have somebody that could do that, it'd be great.
All right, thank you. Let's go ahead and move on to the questions, Jerry.
Okay. Since we're right here on the dashboard, we'll just start here with what's a confirmed case, what's a probable case, and that gets into the question that Dr. Nelson brought up. And I'm just going to turn time to James to go through this.
Yeah, so as Dr. Nelson mentioned, we do get quite a few questions on what a probable case is, and it has changed, as I alluded to earlier, just a little bit as more antigen testing has become available. We also want to make sure it's clear. So I'll just go through what you're seeing on the screen right here. A confirmed case is an individual with a positive confirmatory lab test. So this is a molecular amplification test, or that gold standard, where mostly done at national reference labs, but also can be done at certain laboratories, inside our health district. Probable cases are those, there's a few different options here. So we'll just go through each one. The probable case, the first one is those that are having symptoms that are consistent with COVID-19 and they've had contact with a known case. This is able to be done by the epidemiologists at Eastern Iowa Public Health as they're doing contact tracing. They use very strict kind of guidelines to associate how symptoms and the consistency of those symptoms, and if they're in the timetable that we would expect from having known cases. This is only if the individual does not have a test done. If they have a test done, we take the results of that test. Another probable case definition, and this is the one we talked about earlier, the antigen tests are those for symptomatic people that are test positive with the antigen test because of their slightly less secure about or 100% positivity rate that the gold standard molecular amplification test has, or close to 100%. We do use that as a probable case definition. They are still considered, again, a case. I'll just reiterate, we did take off probable cases earlier a few weeks ago, and we were asked to put them back on. We don't treat probable cases differently than we do confirmed cases. We still act as if they have it, and we still recommend and educate in the same way. Contact of a known case who tests positive with an antigen test, or who a symptomatic person who tests positive. So both of those are probable cases. So if they use that antigen test, they can't be considered probable. The other one has to do with a deceased individual who certificate lists COVID-19 as contributing to death without the laboratory confirmation is listed as a probable case as well. I will just mention that that is done by medical providers. That's not declared by Eastern Idaho Public Health. That's just a reporting criteria that is used by Eastern Idaho Public Health. The providers or whoever declares that, or coroner, excuse me, has that ability to issue that death certificate with those contributing factors.
I just wanted to go back to a couple of things that we are going to start seeing the probable case numbers grow simply because of the antigen testing. And we just don't want people to misunderstand what that means. And so again, we've updated the information with the definitions for probable case and the antigen tests that are now becoming more widely available. And back to Dr. Nelson's question about if someone in a household tests positive, we do not automatically count every other household member as a probable case. As James mentioned, through the contact tracing and the work that's done by our EPIs, identifying if any of the household members become symptomatic within the time period that the infection could have occurred, then those could be considered probable, but it's just not an automatic. So I hope that is clear. Dr. Nelson, is there any other questions specifically about that? Another thing that I would say is we get lots of questions about, this generally happens in hospitalized patients, but it can happen for any positive case. Sometimes multiple tests are done on an individual that show that they are testing positive, continue to test positive since their initial diagnosis. We do not count those subsequent tests as new cases. When an individual tests positive, it is counted only once for the individual. There's reasons that they continue to test to determine when a person may be negative, but those subsequent tests are not counted separately. It is just one case associated with that individual.
I will just add that there has been conversations about if you can become reinfected. Right now, with this virus being slightly newer, we really only have data beginning in March. The CDC, along with the CSTE, has recommended 90 days or 3 months of immunity right now. We don't have any further data to show increased immunity past that. As we get more data, that will certainly be updated, and we're hopeful that that continues to increase as the immunity can last as long as possible, really. But right now, we don't consider cases even retesting or potentially reinfected really for at least 3 months. And I can tell you right now that we have not had a report in our area of another individual, nor have we counted another individual reinfected at this point.
So another question that we get a lot is, what's the process for reporting a positive case?
So the process for reporting a positive case really comes from the Idaho Reportable Disease Rules, where a provider or a laboratory is required to report the positive result to Eastern Idaho Public Health or to their local public health department across the state. As that is done, we do not receive all reports. We just, again, receive the positive reports for both antigen and the molecular PCR. We do not receive them for antibodies. That's not a diagnostic capable test at this point. So when we receive that report, we then start our investigation to understand when the illness onset was, to understand their disease progression, as well as then provide that education based off those two previous questions, really. And then hopefully able to educate those individuals around them or who they've been in contact with, what they might need to expect and what we would recommend them to do. So just to reiterate, illness onset actually determines when an individual's isolation will need to end. So 10 days for cases that are confirmed or antigen testing, probable cases, both of those, they are released 10 days from symptom onset. Now the incubation period is up to 14 days for this disease, 2 to 14 days. That's why their contacts need to isolate for 14 days from the last day of exposure. Again, from the last day of exposure, 14 days for their contacts to isolate so they can help stop the transmission. Again, the disease can present itself up to 14 days later, but cases themselves, once they are symptomatic and have a positive test, they go 10 days from symptom onset and then are no longer considered contagious. So I hope that clarifies. There's two numbers out there. I know, and sometimes it can get very tricky, and we've heard both maybe at different times, but 10 days from symptom onset for cases, and they're no longer considered infectious for the most part. And then 14 days for any contacts from their last day of exposure to an infectious individual.
We've been getting more questions recently from individuals that say, so I saw my doctor, he thinks I have COVID, but never got a test. And so there's a question whether or not those individuals are counted in our case count. And the answer is no, unless there is a laboratory test done, again, either the PCR test or the antigen test, those individuals are not included in our case count. Another thing is, when James was talking about the people that are contacts of cases and have to isolate for 14 days, we do get a lot of questions about, well, can't I just get a test and be released from isolation?
Yeah, we do receive that question on almost every contact we make. And we'll go over the second question that we get on almost every one. The first question that we get is, can I get a test and then go back to normal life? And the answer is no. It does not change the isolation period that we recommend for 14 days, just for the fact that I'm going to take, for an example, on day 5 of that isolation, you go and get a test. That means on day 5, at that moment, you are negative for that test. You'd still have an additional 9 days potentially for that virus to be replicating enough inside your body to then present itself and you be infectious to other individuals. So we're really asking individuals to and encouraging them to isolate so that they can help stop the transmission. A negative test does not mean we don't have testing that can show future disease. We only have testing that can show at that point in time if you have the presence of that virus. So for that reason, we do not recommend close contacts of cases to go get tested right away. They really do need to isolate until time has sufficient time has passed from that exposure. The second question I'll just add on here that we commonly get are, if I was exposed to an individual, so a direct exposure, does my family then need to isolate? And the answer is no. Only direct exposed individuals, or those primarily exposed or directly exposed to the individual that is a case, needs to, and again, that's for within 6 feet and for more than 15 minutes as a general guideline, need to isolate. Coworkers or family members of the exposed do not need to isolate unless that individual then becomes a case themselves and they're within that time frame where they were infectious and around other people. But for the majority of people, that secondary line or non-direct exposure, but indirect exposure through the direct exposure, do not need to isolate. I know there's a lot of indirects and directs in there, and I hope that's clear. But those two questions, getting the test, and then what does my family or my other coworkers need to do, are the two most common questions we get from known contacts of cases.
Another thing that is very important that maybe people don't understand completely is that if someone has gone in to get a test for COVID-19, they should be isolating until that test result is received. If they are not isolating and it comes back positive, they have then created more exposures. And that goes into the purpose of why it's important to isolate, first of all, if you're positive or if you're awaiting a test.
Yeah, we can't encourage strongly enough that symptomatic individuals do need to isolate away from others. Sick people need to stay home. That's our first recommendation, our mitigation strategy. And not just this illness, but all illnesses as well.
You want to talk more about the contact tracing and really what the purpose of that is?
Yeah. So as we've talked about this, really the purpose of the contact tracing is to quickly, in hopes, quickly identify individuals that may have been exposed and ask them to isolate. So essentially the transmission could stop with them. As we identify known contacts of cases and we ask them to isolate and they do so effectively, essentially the transmission really does stop with those individuals. So even if they become symptomatic in our cases themselves, if they've isolated themselves away from other individuals, they're not transmitting that disease to any further individuals, and we can kind of stop that exponential growth curve. If they do continue on and they do become symptomatic, now we have again exposed, from 1 person to 3 people to 10 people, and that's where showing that exponential curve really can't happen quickly. So contact tracing really is about helping individuals identify and give them education about the importance of staying at home so that if they become symptomatic, they're not exposing other individuals as well.
I would just share that we do have instances where we reach out to a case and they refuse to give us their contacts, and there's nothing that we can do to make them give us their contacts. We certainly do ask them to notify their close contacts and give them the same instruction that they should be isolating to stop that transmission cycle. So.
Yeah. And if I may, I just want to comment on something Dr. Ballard mentioned earlier, the concerning trend. And I think it's important to know that for all illnesses, including COVID, we want individuals to seek care appropriately and early. Not getting tested to not maybe be included in the numbers. We've heard that some individuals don't want our numbers to rise, so they're not going to get tested. The concerning trend on that is that they're going to not seek care at the appropriate or at an early intervention time, and then end up really having more severe disease trends potentially and going into the ICU. So I would just ask that all individuals seek appropriate care for whatever ailment they're having or illness, and really seek care through their primary care provider or the ER if necessary, to get some early help with the illnesses that they're facing.
We want to explain again an active case, and that is one of the measures that we use in our response plan. But do you want to take that?
Yeah. So an active case is those that are still under monitoring. So as I mentioned earlier, we look at 10 days from symptom onset and then release those individuals. That's why at times when we report a case, we'll also release them on the same day because it's been 10 days from their symptom onset, not just necessarily 10 days from their date of collection of the test. If we were to solely use just the daily reported cases that we're getting, it could be accurate what's happening right then, but it could also be inaccurate because really we're trying to take into account when the illness onset was. And that really is what's happening in our community is illness onset on that day. So with the active rate, as we look for active cases, it's really those that are based off of the illness onset. That gives us a better understanding of what was happening really in the last 10 days, so to speak. Whereas if we just use daily active case counts, it could be what was happening 14 days ago as well. So the active case, as Jerry's showing here, I think line F2211 there, it looks like there was a Bonneville County resident that we reported yesterday, but also was released from monitoring. They are not in our active rate as their illness onset was at least 10 days previous to 8/19. So this really helps us to understand what the active or current infection rate is in the last 10 days.
I will share that we get lots of questions and concern that if the test is taking that long, that an individual is reported and released on the same day, that it's not giving a true picture of what's happening. And I would just say that I would extend that to people that are not even getting tested, right? Because we have a lot of people in our communities that may be sick but are not seeking testing themselves. In our metrics, we not only use the active case rate, but we also use the hospital admissions. In our moderate or yellow level, it's based on the ICU admissions. And so regardless if tests are taking a long time to come back, test results are taking a long time to come back, or people are not even getting tested at all, we would still expect to see some activity in the ICU admission. So between those two metrics, we feel like it's a good indicator of what is actually happening in the community. I will say that there's no metric that is perfect, and that we certainly are lacking data that we wish we had that would be able to help us make very timely and informed decisions. But based on the information we do have, the active case rate and the hospitalizations, because that's the whole point of our plan, is to maintain hospital capacity, and we'll transition into that here in just a moment. The mitigation measures that we're implementing is to maintain that hospital capacity. So between those two metrics, the active cases that we could expect to turn into hospitalizations, and as well as the occupancy of our ICUs, give us a good indicator of what we're seeing in the community, regardless of testing.
And I will continue, as we have actually had a reduction in the days waiting for test results that has improved over the last 3 to 4 weeks. We still will see these occurrences happening where they're released on the same day. That's not just due to testing lag time, but some individuals may not get tested right away as their symptoms develop. I want to point that out as another factor. They may themselves elect to not go get tested for 4 to 5 days. So by the time the results do come in, they're short on the active case rate.
Another question, and this is a very pertinent question right now, as schools are getting ready to return to session. And the question or debate is that COVID does not affect kids as severely as adults, and the kids perhaps do not contract it or transmit it. We have had our medical professionals, the last 2 meetings, that did share their professional medical opinions that yes, in fact, kids do contract it and they do spread it. But I just wanted to show here on our dashboard, any of these columns you can sort. And so I want to sort that you can see the 0 to 19 number of cases. And we looked at this last night. Do you have those numbers?
Yeah, I do. And if you want to go even to the demographic page, you can also just show that overall bar graph. Right. So while it's not broken down necessarily in this demographic bar graph under 0 to 19, we did spend some time and break that down ourselves. For 0 to 4-year-olds, we do have a total of 56 individuals, with 22 of those confirmed and 34 probable. 5 to 9-year-olds, 57, with 26 and 31 respectively confirmed and probable. And then our 10 to 18, and we did not go up to 19 here, but just at 18, were 267, or 12% of our overall cases were in the 10 to 18-year-olds, with the majority, 177, as confirmed of those 267. So we know that individuals in those age groups, as Jerry mentioned, with the help of the medical professionals that we've had on the last 2 weeks, they do contract and they do have are able to transmit it. That being said, we recognize that there's emerging data that 0 to 10-year-olds may not be able to transmit it as easily. There's a lot of hypothesis on why this may be. Again, we will continue to monitor that, but certainly 10 to 18-year-olds, or the adolescents, really what's categorized as adolescents and not children, really can and do spread it at a high rate quite effectively.
Mr. Chairman, could I ask a question while we're here with the youth?
Go ahead, Commissioner.
Thank you. James or Jerry, I know when we list a death, we list there were underlying conditions that also contributed to this. Is there anything that is showing that these youth that are contracting this, healthy children, do they have underlying conditions? Not that that really matters, but I think some of the fears that are there some people might be able to come to grips with this a little bit better. Is there any way to know if the youth 0 to 19, those cases have underlying conditions, or is that even a factor at all?
That's not a factor in contracting, actually. And that's a great question, Commissioner Mendenhall. Underlying health conditions have no bearing on whether you may or may not contract the virus or the disease itself. Those underlying health conditions really impact maybe the severity of the disease that you're experiencing. So one thing that we're certainly concerned about, and that has been noticed across the United States, is the multi-inflammatory syndrome that's associated with children, that is right now attributed to, at least in partial results, to COVID-19. And I just looked up this morning, CDC has reported 570 cases of those, and that does not seem like a lot, I understand. But included in that is 10 deaths as well with children. And that's a concerning thing for us overall. We don't want children dying. I know that's a small number, but I just point that out, that that's one of the concerns for those individuals in that age group. And those are children really without any underlying health conditions from what they are seeing in those trends for the most part. Does that answer your question? I want to make sure that I understood it correctly.
You know what? Yes. In fact, I think that might, the main thing I took from that is that underlying conditions are not connected with contracting COVID. They would be contributing to the severity and what happens down the road. What was that syndrome again? What was that one that you mentioned?
Multiple inflammatory syndrome, or multi.
Okay. Yeah. Okay. Yeah. Anyway, I think that helps as these youth go back to school. We still have an issue with them contracting it by associating and coming in contact, but underlying conditions are after they have gotten the severity. Thank you. Yes, it did.
And that's why we'll go on. We're really concerned about if there a large outbreak, even in school-age children, maybe actually passing that on to vulnerable adults around them. So,
Mr. Chair, unless there are other specific questions from the board members that you would like us to answer, we can move on to the response plan. But we just wanted to answer some of the most common questions that come to us.
Okay, thank you. Are there questions from the board that need to be answered now?
Mr. Chair, Bill Lake.
Go ahead, Bill.
Thank you very much for pulling all these questions and answers together. Certainly has educated us board members and anybody from the public listening out there. I'm just wondering, is there a possibility, and I'm not looking at giving you guys more work to do, but do we have like a frequently asked questions that we could put together and put out there on the website so other people can benefit from these?
We can certainly do that. I will give a lot of recognition to Mimi Peeler, our public information officer, that works around the clock answering these questions for people that comment on our Facebook page or send the questions into the COVID question line. So yes, we could easily pull that together.
Okay, thank you.
Commissioner Young, did you have a question?
Yeah, I've been hit with a few questions this week, and maybe our director, Raquel, can address this, and maybe we need Michael Kane for this one. But personally, I have gotten reports, and they mentioned this, Jerry mentioned this earlier about, they encourage individuals to stay home, but I have gotten rumors, reports of individuals who've been tested positive. One in particular that I felt was very egregious. What can be done to make sure these people are encouraged to stay home? If we work with our local community leaders or something, that's, I'm very concerned about these people spreading this when they know they have it, and yet because their symptoms are so light, they don't stay home, and it's very concerning to me because of our goal to get people in school and keep people at work.
Yes, Commissioner Young. I would say we do our very best when we're doing the contact tracing, making daily contact with individuals to ensure they understand the importance of staying home. But again, all we can base our information on is what they're telling us. And if they're not being honest with us, we have no way to confirm anything.
Yeah,
However, I would say that if we know about an individual that is positive and that is not isolating, as public health and our board, we do have the authority to issue a specific order of isolation for that individual, again, that would have to be legally enforced. So that would mean our county or city law enforcement acting upon that. I don't know if that would mean positioning a law enforcement official at that person's door to ensure that they don't go out. We've not had to do that, but if you are aware of someone that is known to be positive and not isolating, you could certainly let us know, and we could do some follow-up on that.
And so the public, other public people can also notify the health district or whomever, maybe our local officials, law enforcement, can they be notified?
Part of the challenge, I'm going to just go back to your first statement, is that my belief is the people that are confirmed to have it is just the tip of the iceberg. And we have so many people in our community that either have such mild symptoms they don't even think it's COVID, or are not going to get tested regardless, and they're out there in the community and are more risk to our population than the people that are actually confirmed to have it. And so that's why it goes back to the importance of all the mitigation measures that we've been talking about. If you're sick, stay home. If you choose not to get tested, that's your right. But please stay home so you're not infecting other people with whatever the illness is. When you're out and about, physically distance from other people. Maintain that space. That's going to minimize your opportunity to become infected. And when you can't maintain the physical distance, wear your face covering. And then again, frequent hand washing. All those things combined are what's going to slow the spread of this illness and help us get through and get back to having as normal life as possible.
Okay. Thank you, Jerry.
All right, Jerry, let's go ahead and move on to what information you had for us on the plan.
Okay. Just gonna pull up another document. Okay, so on this document that hopefully you can see on your screen now, it does recap the actions that were taken by the board at our last meeting and made some changes to the high risk level or the orange level of our response plan. And again, this was done in very close consultation with our hospitals. And we go back to the primary goal of this plan is to maintain hospital capacity. I'm just going to say it again, it's not just for COVID patients, it's for all patients that need hospital care. Whether it's a COVID patient, whether it's a heart attack patient, someone that's having a stroke, a burn, a car accident, whatever it may be. Our hospitals have limited capacity, not just in their tools or, for example, ventilators, but staffing as well. And specifically, ICU staffing is limited. And so we're doing these things to ensure that the spread of COVID is a manageable level, that it's not overwhelming our hospital all at one time. So the change that we made last meeting was taking out the active rate of 20 per 10,000 population by county and bumping that up to 50 per 10,000 population and basing it on the entire region. In additional thinking about this over the last week since our last meeting, we are proposing an addition to that based on that same change that was made. But in yellow, you will see we would like to incorporate the language that says an individual county that reaches the rate of greater than 50 per 10,000 will be reviewed by the Board of Health for potential movement to the high risk level. Additionally, if the active rate of cases for the entire health district reaches that threshold, the entire district would be considered for movement to the high risk level. When we look at this rate of 50 per 10,000, and based on what we would anticipate to come out of hospitalizations, and Idaho's current hospitalization rate for positive cases of COVID-19 is 4%. And so taking that and our population, we backed into the rate of 50 per 10,000 that we would anticipate 46 hospital admissions every 10 days. And again, the 10 days comes because that's an infectious period for a confirmed case. And so every 10 days we could anticipate based on what the current hospitalization rate is for our state, 46 patients to be hospitalized. Now that's just general hospitalization. It does not include the ICU. And the ICU rate is captured in the yellow category. So do you have anything to add to that? So are there questions by the board about this proposal? I would say that it does address some of the concerns of individual counties. You know, those with lesser populations that still may have a very high rate and do have a local hospital, that hospital could very well be overwhelmed with a much higher rate. And so I think it is wise for us to consider that we may need to do something for an individual county if they were to reach the 50 per 10,000 threshold. But again, if our entire district is reaching that level, the majority of those patients are going to be funneling into our Idaho Falls hospitals and Madison Memorial to a lesser extent, because that's where the ICU capacity is in Idaho Falls, that we would need to take action across the board to slow things down to maintain that hospital capacity.
Mr. Chairman, I have a question, please.
Go ahead.
Jerry, with that, we have been viewing the hospitalization rates along with the entirety of cases. And I'm a little concerned, is there any potential or any way that we could look at this and say regionally 50 per 10,000 threshold, and taking into account these small communities? Salmon, Lemhi County has been most vocal in the last week about this. Is there any way we can include a metric that says, and 50 per 10,000 threshold and a daily admission of 30 or more cases? Is there any way we can blend in the hospitalization? Because we're not seeing the big rush on hospitals right now as Jefferson County hits a high and Bonneville County hits a high. Do they need to go hand in hand, or can we just stay with 50 per 10,000 and say we have this many cases? We don't have the hospitalizations yet, but we have this many cases. Am I making sense? I'm wondering if we need to put the two together, because a lot of the concern has been not the cases. Yes, people are sick, but the hospitalizations have not been on that dramatic of an increase. Does that have any merit, or should we stay with the cases only?
So Commissioner Mendenhall, I'll start and then James can add on. We already have that incorporated in our plan. And again, let me just pull up our current plan as it stands on our website. If you'll give me just a moment. I'm sorry, I can't type and type at the same time, type and talk. But we already have metrics in our plan that try to capture both of those things. And it's not and, it's or. So the active rate, again, is one measure that we take into consideration that we would expect to generate the hospitalizations. What we have been seeing, as we reviewed last week, is we were seeing that. When Bonneville County was hitting this rate, we were seeing that number of ICU admissions in our hospitals. The other metric is that the hospitals are reaching the ICU occupancy of 90%. And this is where it came in with dialogue with our hospitals. They have done a good job of expanding as much as possible their capacity. And based on their input, that's where we felt and they felt that we could increase this rate. So you have,
yeah, I would just add, I think we do consider both. I think the reason for the rate there is really the potential for preventative mitigation strategies to be implemented so that we don't see the hospital capacity getting to that point. It's the hope, or that next step, because there is certain lag time between the cases and the hospitalizations. I'd also say, and maybe to your point, I hope I'm not misrepresenting your intent, but I think that this is a fluid document. Just as the board made the changes in collaboration with the hospitals last week on the rate of 50 per 100,000, if we're not exceeding the hospital's capacity, and if we do hit that rate, which I hope we don't, that we would then look and consider what the hospitals are saying at that point and make that change. That's why the wording of potential movement, I think, is a good plan. We have a good plan, but again, we want to make sure that we're using the most up-to-date information we have, and that means going to the hospitals and having the collaboration with them.
I would also say that part of our dialogue has been that if something happens outside of these two metrics that we're using, that the hospitals are saying, okay, hold on, something's happening and we're getting to our breaking point, even before they reach that, that rate or, you know, the metrics that we've included in our plan, that our board has committed to taking that input from the hospitals as far as what their capacity is, and using that to make decisions for mitigation measures.
Okay, thank you. Are there other questions? It's
Mr. Chair, Bill Lake.
Go ahead, Bill.
The question I have is where it says Idaho's current hospitalization rate is 4% of all positive cases. That word positive, we've been using confirmed, probable, and active. What does positive actually mean?
Yeah. Confirmed and probable.
So it's the combination of those two. Okay, that answers that question. The other question I have is that where it talks about 46 hospital admissions every 10 days. So every 10 days, 46 people go in the hospital. How many people are we assuming leave the hospital so that we can factor in what the actual number of people in the hospital is going to be over time?
Well, I know Casey Jackman had to jump off, but if Dr. Ballard or David Hoffenberg or Dr. Gonzalez would like to comment on it, what we're hearing is that those that don't need the ICU admission, which in fact create a longer stay, I mean, their length of stay is longer. Those that just need hospitalization tend to be there for a shorter period, so for a few days. And I don't know if the hospitals want to comment on that anymore, if they're still on.
Hey, this is Tim Ballard. I agree with what you're saying. Many of our patients that are admitted to our medical surgical units are admitted for a duration of less than 10 days. Those that are longer are the ones that have graduated, so to speak, to our ICUs. But for the majority of patients that we're seeing in our facility, their disposition time is under 10 days. Over.
Thank you, Dr. Ballard. Bill, did that answer your question?
Yes, thank you very much.
Good questions, and I think a good change to the plan. It makes good sense. It addresses the concern that came up from our actions last week, and it's also a number that was in collaboration with the hospitals. They helped us in developing this number, so it falls in line with what they expect their expectations would be. Any other questions from board members? It will require a motion to make this change, to basically just add that second wording to what we had done last week.
Mr. Chairman, I would make a motion we accept and make the changes as identified in our regional plan.
I would second that.
Okay, we have a motion and a second. Is there any discussion on the motion? Hearing none, I'll go ahead and ask for a vote. All in favor, say aye.
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 Is there anyone opposed? And did anyone abstain? Okay, thank you. So Jerry, we'll ask you to go ahead and make that change then to the plan. And you know, it's been somewhat surprising, but I'm glad that the public is really using this plan. They're looking at it and helping us with it, helping us to understand where the needs are, and they rely on it in many ways. And I know the school districts do as well. And so, again, we appreciate all the work that has gone into developing this plan, and look forward to it being updated and on the website then as soon as you're able.
Yes, thank you, Mr. Chairman. I guess I would just ask, is it your desire that we send out a press release announcing the changes made to the plan today? We will definitely post it on our website and on Facebook.
I personally do not think that it's necessary. I know we do have members of the press that are online with us. I think that word gets out as long as it's on our website. Does anybody disagree with that? Okay. I think that's fine. I don't want to overload the public with press releases that sometimes becomes confusing. So
I will just share that the word has not been put out publicly, but it will be today that we have had another death in our health district that came to us late last night that will be released today.
oh, I'm sorry to hear that. Is there any other business, Jerry, that you need us to take care of today?
No, Mr. Chairman, that's all for today.
Before I close the meeting, I'll allow any board members, any questions you have. I don't want to cut you off.
Mr. Reed, Chairman Reed, this is Commissioner Minor. First off, I once again want to thank Jerry for all of her work and on all of her workers there. They're doing just an amazing job. And, you know, we are flying in uncharted territories. I really appreciate the positive, for the most part, comments through the public forum as far as the emails that we're getting. I would like to just go on record of there's one cowardly citizen from Lehigh County that just leave Jerry not the nicest voicemail in the world. And there's no room for that. We're all trying to work together. So I just hope that we can continue to keep things positive and just try to get through this.
Okay, thank you. Is there any other comments? Well, I want to thank all of you for your time again this morning. We have been, because you've been willing to meet on a weekly basis or more if needed, we've been able to be responsive quickly to what we are seeing. I am grateful that we have seen numbers reducing recently, and we will just continue to hope that continues. The timing is good as schools are trying to get back in. So we will hope that everybody will do everything that they can, and that's following these strategies that have been outlined by Eastern Iowa Public Health. Stay home when you're sick, keep your hands washed, wear face coverings whenever you're in public and not able to keep a distance. Just do everything we can. If we all do that as a community, we will continue to see these numbers come down, and we'll have success in getting our students back to school and have our lives as normal as possible and be able to continue. So we just continue to ask everybody to do that and to spread the word and encourage others. I think education is helping everybody understand how important this is to do each one of these strategies. So thank you again, all of you. Go ahead, Jerry. Did you have anything else before I close?
Yes, it just goes along with the same lines that you're already mentioning, that as we get school back in session, which is already happening in our region and will continue over the next several weeks, bringing those groups of people together, and for the fact that people can be asymptomatic and still be spreading the virus, the importance of physical distancing, and we know in our schools that's going to be very, very challenging. And so with that being said, the other measure that goes hand in hand is the importance of the masking to keep that spread minimized as much as possible.
Yes, absolutely. And I have heard some misunderstanding in schools. I would hope that every school this meeting would enforce that, and because it will give them the best chance of keeping their students and teachers safe. So thank you again, everyone. We'll go ahead and bring this meeting to a close. We'll plan on meeting next Thursday at 7 a.m. again, unless something changes, and you'll be notified.
Thank you all very much for your time today.
Thank you.
Great job, Brian.
Thank you.